Welcome, everyone. Welcome to Past and Present with Allison Gilbert. My name is Andrew Engel, and I'm Senior Programmer at Reimagine. Our mission at Reimagine is to help people of all backgrounds face adversity, loss, mortality, and channel all the hard parts of life into meaningful action and growth. I'd like to thank Christina Serio and Domani for Grief for their endless support of this series. We're so grateful to you. And I want you all to mark your calendars for the next Past and Present with Allison. Her guest will be pastor, spiritual life coach, and healthcare activist, Corey Kennard, and that will be on April 28th. And I'll be posting a link to that in the chat. And now, it's my pleasure to introduce Allison. Allison Gilbert is the author of numerous books, including the forthcoming biography of Hearst newspaper columnist Elsie Robinson, to be published by Basic Books, Hachette, in September. Her most recent book, Past and Present, Keeping Memories of Loved Ones Alive, reveals creative ways to remember family and friends who we never want to forget. And you can follow Allison on Instagram, Twitter, and Facebook. She's everywhere at A Gilbert Writer. And with that, it's my pleasure to hand it over to Allison, who will introduce our esteemed guests.
Thank you so much, Andy, and Reimagine and Domani for Grief for providing this incredible platform for us to be together for the next hour. I know we are all busy, and whether or not you're on the East Coast coming to us in the middle of the day and it's your lunch, I want to honor that time, and I promise we will be here for just 1 hour. We will not go over. I know how busy you are. And if you're on the West Coast and it's just in the morning and you're just having your cup of coffee, I know that you're busy too, trying to get kids off to school potentially or get your day underway. And so if you have to step away, what Reimagine kindly does is record this conversation. You are going to meet or re-meet these two incredible women, these two incredible authors. And if you have to step away, don't worry about it, because Reimagine records this conversation. You can always pick it up later on. So no pressure. I want to say first that we are in a really challenging time. And for the next hour, let this be something that heals. Let this be something that stirs, and let it just be a time just for you. So if you would like to put the distractions away, you are more than welcome to do that, to silence your phone and just be with Dr. Horton, be with Hope Edelman, take advantage of this hour, as I am going to do. So I am going to start by saying congratulations first to author Hope Edelman, and here is why. Number one, Hope Edelman's book, The After Grief, has just come out in paperback. Yay! And number two, after a long COVID haul, her Motherless Daughters retreats are back in person. Hooray! And so I want to start with author Hope Edelman and say first, welcome. And then I want to dig into both the paperback and your retreats. And then, of course, I will get into Dr. Jill Horton. So Hope, let me start with you. Congratulations.
Thank you, Allison. That's quite an introduction. Greatly appreciated on both fronts.
So let's start with the Motherless Daughters retreats, which I have been fortunate enough to be a co-host of one of them. They are remarkable. You have been forced, like so much of the world, to go online, but they are back in person. First, tell everyone what these retreats are, what they can get out of them, and hooray, they're in person. So how can folks even know about them, and where are they?
Well, thank you so much, Allison. The Motherless Daughters Retreat started in 2016. I began leading them with Claire Bidwell Smith, and we do two different retreats, one for women who are up to age 21 when their moms died. They can be any age now, and the retreats are very intergenerational. And also one for women who were in their 20s when their mom died. And one of those is starting this evening. They go from Thursdays until Sundays. We hold them on West Coast and East Coast sites. There's a big one for early loss that will be coming up this October in Connecticut. But there are 4 days of discussion and story sharing and coaching exercises and bonding, eating great food wherever we are, being taken care of, nurturing ourselves, and also allowing others to nurture us. The women say that they're life-changing events. We've had almost 350 women go through them so far. And yes, you co-facilitated one with me in Connecticut. And I think it was a remarkable experience. There were 20-something women there, and really unforgettable.
And I'm just going to say before we change the topic is that looking behind you, that is a real picture of the beautiful location where the retreat takes place in part, correct?
That's true. Topanga Canyon, California. It's going to be our third live retreat here in Topanga, and we hope to have 1 or 2 more this year here as well. And so I'm sorry about the background noise. There's birds, there's trucks. I'll go inside if it gets too noisy, but I wanted people to experience this beautiful place, and that sort of comes with it, you know, the natural environment.
What's so hilarious about that is that you might have to go inside because of birds. Me, a New Yorker, I would have to like close my door for like the traffic. Yeah, totally different vibe. Before Hope, I talk about the paperback release of The After Grief. Now you're going to get wind of why I asked you about the retreats first, is that Dr. Horton is in the house. So first to say hi, Dr. Horton.
Allison, it is so nice to be here with you today.
You too. So you are joining us from Winnipeg, Canada. And why I wanted to start talking with Hope about the retreats is that your book, We Are All Perfectly Fine, you are a general internist, you are an MD, you are a physician. And part of your work writing that book is that you went to a retreat for doctors to really come to understand what was causing fatigue, what was causing emotional drain. When you as physicians were feeling so vulnerable, you yourselves went to a retreat. So tell us about that, and then I'll back into some of the themes from your book, We Are All Perfectly Fine. What was so restorative about a retreat for physicians?
Yeah. Well, you know, it's funny, Allison, this is when I hear Hope talk about this, you know, the transformative aspect of a retreat, spending 5 days together in a new environment. There's nothing she needs to do to convince me that that's true, because I know it in my bones. And so I participated, and, you know, it's sort of the scaffolding of my, my book, as you know, it became a way for me to tell a story I had been trying to find my way into for more than half my life. But I participated in a retreat for physicians in rural upstate New York. I'm not sure if there is a rural upstate New York, but outside of Rochester, New York, at a retreat center in Batavia. And it's a place where for years, physicians have been going as part of a program at the University of Rochester run by physicians to learn skills around meditation and mindfulness and new ways of coping with some of the really difficult and traumatic experiences that inform so much of our hidden lives in medicine. And what's really interesting is all of this for me happened before the pandemic, and, you know, all the grief and trauma that I had been carrying, some of it professional, some of it personal, the loss of my sister a few years earlier before I went to that first retreat had been, you know, a tremendous shaping event in my life. But of course, everything that has happened in my profession during the course of the pandemic, all of us have had trauma in the last 2 years. There have been some very specific and unique traumas that have happened in the medical community. So this idea of going away somewhere to sit, to be in community, to form relationships, to learn skills, to share stories, to heal one another. It absolutely resonates with me when Hope talks about it as being one of the best cures that anyone has ever offered me for anything.
I'm curious, Hope, in your book, The After Grief, which again has just come out in paperback, so it's much cheaper if people want to get that copy now. Why is community? Why is the support of others who have been through a similar experience so transformative? And then, of course, I'll ask Dr. Horton the same question.
Well, we're communal beings, aren't we? And we are meant to be in relation with others. We need each other for physical survival and also for emotional support. And I would posit for emotional survival as well, Allison. That is the aspect of grief that was minimized in the 20th century, the social aspect in favor of the psycho-emotional aspects of grief. There's also the physical and the spiritual aspects, but the social aspect's a very important one. And when we think back to before the 20th century, people used to grieve in community. The village came together to mourn the passing of one of its own. And in the 20th century, we started thinking about mourning as something that was individual and interior. And we lost a lot of the communal aspect of it. So these retreats that I lead aim to bring that back into the lives of women who are traveling what I call the long arc of grief, meaning that they are years and in some cases decades past the loss of their moms, but they are finding that this primal loss when they were younger keeps reappearing in different ways, and they need to keep readjusting. And so they really want to be in the presence of other women who can understand that, who know what it's like to have lost a mom when you were young and to face various life challenges throughout the lifespan as a result.
I understand that that could be quite vulnerable, right? We might crave validation, but sometimes it's scary to admit that we need support or to feel like we are going to be perceived as being weak. Not that we are, but the perception that some of us are fearful
Right.
of. And I'm imagining, Jill, among physicians, that might be even more of the case, where physicians are trying to be perhaps stoic, know it all, come across with a sense of authority and autonomy. What is that like in a retreat setting for physicians, and how do we break through that facade in that environment?
That's such a wonderful question, Allison. And, I think for us, when we look at medicine, so much we can trace in the origins, not just of the personality types, the kind of people who typically go into medicine. We know that there are certain characteristics that classically define the physician personality, a type A, sometimes we call it even a type A plus personality, high degree of perfectionism, neuroticism. And then very early on in our training, we're encouraged to what I often call just disembody. We are hungry, we're told work through your hunger. You're exhausted, you work 24 hours, you're told work through your need to sleep. Just hit override button. And I think from a very early point, we detach from our ability to name a lot of our physical and emotional states. And therefore, as we move deeper and deeper into our careers and we acquire one loss after another, because, many of us, especially the earliest patients that we care for, those patients, they imprint on us. Those losses loom larger than life for the rest of us for most of our lives. We always remember those cases in particular. And therefore, we kind of arrive at this stage where, probably similar to what you and Hope find at retreats, people have these experiences that were so central to their identity formation, but they've never metabolized any of it. They're still stuck at a stage where they never really acquired the vocabulary to name what was happening in their bodies at those times, or, identify certain reactions as normal parts of grief. So what's so interesting is, you have this group of highly trained, highly intellectual, extremely sophisticated and capable people who, when you ask them, what does grief feel like in your body? They go, I don't know. I'm not sure. Do I have a body? You know, so it's a really interesting relearning, you know, basic things that unfortunately have sort of been wiped out of us, erased from our master programming. And there's a lot of healing and actually a lot of joy in that relearning as well.
I want to talk about words and naming and why that's so important. It seems like a very natural question to start with you, Jill, since I'm with you now, then I'll go to Hope too, is we are all perfectly fine. Why that name for your book?
Well, there's just a touch of irony in it, of course, but you know, I think it works on a few different levels in terms of how it manifests in the book. And you know, the first thing I often think about is when we go to the doctor and we have a problem and we're worried. One thing we long to be told is that everything's going to be fine. We long for some kind of reassurance that the thing that we most fear is all right and is going to be okay. And then the second thing in our culture, and I think this is probably something that both of you hugely relate to, you know, when we are struggling, when we are carrying heavy things that we struggle to name, our typical reaction, and again, for reasons I just talked about, is often to just say, I'm fine. And we often say, you know, a physician, the minute they tell you they're not fine, they are really not fine. Like you really have to worry that that person is at the highest possible risk because it's a very late stage finding. But then the title is also this other idea. You know, I sometimes think of what Jon Kabat-Zinn talks about, the idea of going where the water is deeper, that when we can hold the space for each other to, again, metabolize, process, work with, learn to work differently with some of our experiences, when we can figure out another path to a different space, there is a place where we can start to realize that, you know, the things that, as you say, we often pathologize, the things that we think are fundamentally wrong with us, flawed with us, you know, all these aspects of it, that when we can access another level of just existing, being, sitting with those experiences, that actually we can find that we are okay, that there isn't actually anything wrong with us. And I think a big part of the work that I have learned and that I now have the privilege of teaching to largely to clinical health professionals, but to other people as well, is really how to make that transition, which is partly a paradigm shift, a cognitive reframe, but is also really believing that, you know, there's space for us to exist with all of our experiences. You know, we often do a lot of comparative suffering, and, you know, there's a wonderful realization, I think, for us that comes when we realize that our suffering is very unique, but it's also extremely common to everyone. There's a wonderful healing that occurs when we start thinking about our, you know, the ways in which our suffering is more like other people's suffering, as opposed to it being as terminally unique as we often feel it is when we carry it alone.
The commonality, I think, is what is so healing, right?
Yeah.
That we are all of a piece, I think is somewhat of a way to temper our frayed nerves, our frayed energy levels that feel somehow out of control and unique. But I think once we put ourselves in that common bread mindset, there's something that feels like a salve almost. And I'm wondering, Hope, for you, you came up with the term the after grief. It's the name of your book. What does the term the after grief mean? And why was it important for you to kind of really frame your book in that way?
Well, I've been a writer for almost 40 years, so words are my currency, but words are important to everybody, aren't they? The languaging that we use to talk about loss determines the kinds of experiences and expectations that people have. And those terms are so culturally relative. And we're talking about predominantly white, Western, Protestant culture, and this idea that we need to get over a loss or get through a loss or get past our pain. And I was sitting here, my mom died when I was 17, my father when I was 40. So both of those losses are in the past. My mom's in the distant past at this point. And I was thinking, as I was writing The After Grief, which was about how grief keeps showing up for us over a lifetime, how we can't expect that after 2 years or 10 years or even 20 years or more, that we won't still miss that person, that we won't still at times long for them. or feel sad about what they lost. That's a natural cycle in the bereavement process, but it's way more protracted than most people realize. So I was thinking, what is this term for what comes after grief? Because grief, I think, is an excellent term for that acute phase, the first year or two, when we're really overcome by despair and confusion and sleeplessness, and we're trying to adjust to a world without this loved one in it. But then it phases or shades into something else, and we didn't have any word for that. And I kept thinking, what comes after grief? What is this thing that I feel now, 40 years later? What is this thing that keeps showing up for me periodically, though not frequently anymore, but still painfully? What comes after grief? And I thought, well, we'll just call it the after grief. And I'm watching that term now start to be introduced and used in the common lexicon, which couldn't make me happier, because I think we do need a name for what comes next.
And have you found, Hope, that there's a difference with the after grief along gender lines? Do men experience the after grief differently than, let's say, women? Does it matter who you are in that continuum?
Oh, there are so many factors that determine how any one person's going to respond to and adjust to a loss. There are what are known as masculine and feminine styles of grief. Not all men grieve in a masculine style. Not all women grieve in a feminine style. I read some research that says about 85% of each gender identified individuals will grieve according to that particular, type of grief. But men tend to grieve through action, through problem solving, through doing things to help them feel connected to their person or help them feel better. Whereas women are more likely to, or the feminine style is about externalizing grief, but it's not binary. Research shows that those who can adopt both of those styles tend to adapt well or best over the long term. So those who externalize their grief, who want to talk about it, who will cry as a means of emotional release, but also grieve through action and problem solving, and vice versa, tend to be those who can adjust best over the long term. But I want to emphasize the long term, because when we're talking about languaging, I think we have to acknowledge this new DSM designation of prolonged grief disorder, which exists now as a diagnosis. It's a new diagnosis that practitioners can use after 2 years. They say if someone is still having trouble after 2 years after a loss.
I think it was actually after a year.
Is it
No,
one-
I think
oh,
it's
it's
actually
1 year?
after a year.
Oh, I'm in my mind with the after grief, which I say comes at about the 2-year point. So 1 year, 1 year after a loss, if you're still having trouble with daily functioning, or still preoccupied with thoughts of the deceased and the death. After 1 year, you can get this diagnosis, and then insurance can cover your therapy or your medication. But prolonged grief disorder as a term is really problematic, because prolonged means something's going on for too long. And I don't think we should be putting a time frame on an individual experience. And disorder means abnormal.
Let me pause you there. I want to explain the conversation that you have pivoted into for those of us who haven't read your column that you co-wrote with Rebecca Sofer from Modern Loss. For those of us who haven't read the New York Times piece, let me pause just for a second for a brief housekeeping bit of interruption before I pivot back into that conversation.
Sure.
Number one, if you are starting to have questions about what Jill and Hope are talking about, please put them in the chat. What will happen is that Christina Sirio, who is here, will go through the chat, and she can wave. Hi, there's Christina. She will go through the chat, and then she will identify those questions that we hope will be applicable to the most people. So as we are talking, please put your questions in the chat, and then we will read them. Christina will read them, and then she will actually address them to either Dr. Horton or Hope Edelman or me. If you have a question for me, that would be great. I will turn those questions over to Christina at about 1:35 Eastern time, 1:40 Eastern time. So please don't come here and then feel disappointed that you didn't ask directly to authors Hope Edelman and Dr. Jillian Horton your questions. They are here for you. So don't leave disappointed. This is your chance. So please put your questions in the chat. Number two, if I forget to do this later, I want to do this now. I want to remind you that when we are done at the top of the hour, I do not go long. I respect your time, but that doesn't mean the conversation has to end. Dr. Horton is on Twitter. She loves engaging there, and she is on it on Twitter. Wow, I don't know how you are so good, but she is at Jillian Horton MD on Twitter. So if you do want to follow her there, that's how you can do it on Twitter. Hope is everywhere. Hope _ Edelman on Twitter, Hope _ Edelman on Instagram, and Hope Edelman author on Facebook. Of course, we would not be here. I feel like I'm doing a station break. We would not be here without Damani for Grief. And so Damani for Grief has a community page on Facebook. That is a wonderful private place. You ask to be accepted, you get accepted, and then that's a place where you can vent, you can share, you can laugh, you can cry, you can commiserate. It's just a wonderful place to continue the conversation that we are beginning today. So that is the Damani for Grief community Facebook page. In addition, Damani for Grief has an Instagram page as well. So just wanted to remind everyone that just because we are kind of constructed in an hour here, that doesn't mean that the conversation has to end. Okay, so that is what I wanted to say about that. Now, back to what Hope Edelman was talking about, which is that New York Times piece. So there was a New York Times piece. The article is called "How Long Should It Take to Grieve? Psychiatry has come up with an answer." And basically what this article is talking about is that when you have health insurance and when you go to get reimbursed for going to a therapist or going to a medical doctor like Dr. Horton, they have codes, right? And that's how you get reimbursed. You know, they put in a code and that's the diagnosis. And so what we are talking about here is that the field of psychiatry has come up with a code for prolonged grief. And there's a debate of whether or not we should be classifying prolonged grief at all. And that by designating it as something that seems to be a mental health issue worthy of a diagnosis code, are we therefore calling out something that should actually be considered normal, right? That if it's a code and it's considered a prolonged grief and that's considered a problem worthy of diagnosis, is that an issue? And so Hope, you've definitely started off the conversation. I want to flip it to Jill. What do you make of this?
You know, I think Hope laid out a couple of really important distinctions that we would probably all agree on. And the first one is, you know, there is a profound relief and even catharsis, I think, that we offer someone when we give them, as she said, a vocabulary to name their experience, especially when there has not really been a word that would afford an individual to then have more understanding of the complexity of their reactions, or, you know, the power of naming something. It makes it real. So that is very important. And, you know, we experience that relief all the time when a patient is having symptoms, they go to the doctor and you say, this is what you have. But I totally agree. Absolutely. There is a line, and it maybe isn't even a fine line, between that very healing aspect, which is validation, and pathologizing. So taking something and saying, this is your experience, but your experience is a disorder. Your experience is an illness. And this has a lot of different connotations, as Hope points out, in many different pitfalls in terms of how we conceive of ourselves. Gee, if I have a disorder, there's something wrong with me. There's a pathological problem, as opposed to this is neither a normal or abnormal reaction. It's a reaction. It simply is. This is just my experience. It has a name. But again, when we veer into that, sticking it in a manual of disorders, it's really interesting because the day before that New York Times came out, my friend and colleague, Harvey Chachinov, some of you may be familiar with his work. He's a renowned palliative care researcher and psychiatrist, also based here in Winnipeg. And he had tweeted out that, he had just been talking to a patient about a long period of grief, and he had counseled her and reassured her, grief doesn't have a watch, grief doesn't have a calendar. And then this article came out the next day, and I thought, oh, I guess it actually does. So it's a really interesting way of looking at it. And what is also important, and I think just interesting on this side of the border, we don't face some of those same pressures. We, of course, have universal healthcare here, which has its ups and downs, but overall more ups and downs, I think. But we don't face, that fight with insurers, right? I don't have to diagnose somebody with a problem in order to continue providing them care through their care provider. I can continue to see them at my discretion, whether or not they have a grief disorder, or I just feel that they would benefit from my ongoing care, if that's my area of practice. And I think that's another way in which, when we start to unpack the motivations for people naming things these ways, giving this kind of language to problems, we start to see that it is actually, there are a lot of outside influences that maybe are not in the best interest of the person who is simply wanting to move through this experience, and not necessarily even getting to another side of something, just learning to live with it and exist with it.
Hope, I know you're chomping at the bit. I know you want to respond, but I do want to just read very specifically something that might help frame your response, because I see you sitting forward. I know you have something to say. But let me just read this one little piece that I think will help really drill down, perhaps, and frame your response, which is, these are the people that this diagnosis is trying to capture, okay? It is trying to figure out for what they call a narrow slice of the population, and I'm looking at the wording now, who are, and this is what the New York Times article, this is the group, who are incapacitated by their grief, who's pining and ruminating 1 year after a loss. Those words are very specific. Rumination is a very specific verb, word, and unable to return to previous activities. So my question back to you, Hope, is, those do seem like very specific and, again, narrow concerns that may be worthy of being under some sort of extra psychiatric care, worthy of being demarcated by that kind of clause. And I'm wondering what part of that makes you push away when the slice of the population has been defined as being so narrow?
You know me well, so you know that I had a lot to say about this, Allison. And I want to begin by saying, for that slice of the population, it is critical that support be available and that it be covered to the best of health insurance's ability to cover it, or willingness to cover it for them. There's no question about that. I would never stand in the way of those people getting the kind of assistance they need. But according to the Center for Complicated Grief at Columbia University, that's about 12 to 15% of mourners. And my concern is that the wording of this diagnosis, prolonged grief disorder, will benefit or help the minority at the expense of the majority, because we have seen time and again how languaging influences cultural messaging. And already I've been hearing from people who say, so if my grief lasts longer than a year, or I'm still having trouble after a year, that means that I have a disorder and I need to be medicated or I need to go into therapy. And I want to, I'd like to point out something that is rarely discussed in the bereavement community, and I think needs to now that there is this new 1 year threshold that's getting out into the public consciousness, which is grief as a social justice issue. There's also a portion of this population that cannot begin grieving until more than a year after a loss occurs. Let's say there is a violent or traumatic loss. It is now well known that that trauma needs to be stabilized first before anyone can access the psycho-emotional aspects of grief. And that violent and traumatic losses disproportionately affect communities of color. There are also individuals who can't begin grieving for a year, who have to push aside or compartmentalize their grief because they can't take time off of work, or because they have childcare or elder care responsibilities, or because they have to handle a complicated estate. And so they're not able to attend to their own bereavement needs for more than a year. This is not that unusual. But if they were to begin having the grief response at the 2-year point that other people were able to access right after a loss, will they be diagnosed with a disorder? So we need to really make sure that those who are diagnosing individuals are doing very, very intricate assessments of that particular person's context and needs. My concern is that this diagnosis will be overused.
I am so grateful that you brought up the piece about the diverse experience of grief among different populations, the experience of grief specifically among the Black community is something that the New York Times is going to get a lot of PR out of this particular Zoom session, is a piece that I wrote about in an opinion article that I wrote for the New York Times several months ago called "The Grief Crisis is Coming." And in that op-ed that I wrote for the New York Times, I talked about Black grief and how that is different and across the generations and how that impacts families over time. So I am grateful that we have had this conversation, at least a little bit here today.
Yeah.
And as promised, with 20 minutes left in our conversation today, I see the chat has been heating up. And so Christina, now that Hope has primed the pump, now that Jill has greased the wheels, I want to make sure that we go to everyone who has joined, who has a question today. I see lots of nodding heads. I see lots of people who are kind of leaning in their chairs. And so I'm interested, Christina, what questions do you have percolating to the top here today?
The first one is for Hope. It says, do you think having prolonged grief, now recognized as a disorder, benefits people in the workplace in terms of needing accommodations related to grief?
Oh, I'm not sure how it's going to play out in the workplace. I mean, I know right now in the US, and Jillian, you may know this as well, that the average amount of paid bereavement leave in a workplace is 3 days, which is a travesty. That's not even long enough for people of some cultures or religions to have their funeral or finish their mourning periods. So will it, I don't know. I think we need to see how it's going to play out. But my deep concern is that people will ask for the diagnosis or want the disorder because they will need it in order to have their wake or their Shiva and have paid time off. There's a lot of people in this country who can't afford to go into unpaid leave to attend to their bereavement needs. And there was a bill that was proposed in the US Congress to extend bereavement leave. I know in the UK now, people can get paid bereavement leave for 2 full weeks after the death of a child. I'm not sure if it's extended to other forms of loss. But what I'm saying is that instead of manipulating, the words or the language or the diagnoses, we need systemic change. We need paid bereavement leave. We need better conversations and support services that are free or low cost. We need to increase the understanding about how grief works and not put a time limit on it or imply that a time limit needs to be put on it. So, I mean, it's systemic change that we need, not just, in the workplace. I think it remains to be seen what will happen with this diagnosis.
I want to just be additive. I see in the chat, there's been some conversation about an advocacy organization called Evermore.
Yes.
I think that is a wonderful resource to learn, to join, to get smarter about what we're talking about here. I know that Damani for Grief has long been a leader, talking to the leadership of Evermore to see how the funeral profession can get involved and be on the front lines of making sure that individuals who have just suffered a loss don't go away into the ether unsupported. And so, again, I think Evermore is a great place to find out more information. The woman at the helm of Evermore, Joelle, is just a force. And so if you do want to get smarter, please look up Evermore. I highly recommend doing so. So Christina, what other questions do you have?
So we have two questions about COVID. One person says, the traumatic global collective loss of the last 2 years, do you think that we all have that disorder? And a follow-up question about COVID. COVID is bringing up memories of past losses for people and they feel like they're grieving them again.
Dr. Horton, you want to take, that's a two-part question. The first one, do you feel that everyone has some sort of prolonged grief disorder? I would say, of course, no. I think that's a very dangerous thing to say, but I'm curious what you think.
Yeah, so spoiler alert, I would basically say the same thing, that the minute we try to apply a universal label to everyone's experience, we reduce we sort of cheapen the dialogue, actually, and we put words in people's mouths. We label experiences in ways that may not at all feel reflective for people. And some losses have, first of all, as we acknowledged earlier, I mean, the impact of this pandemic has not been borne evenly in our communities. So, there is a huge equity piece, as we know. Even in Canada, the disparity is not quite as great across all provinces in terms of which groups have borne the brunt of morbidity and mortality with COVID, but certainly for us, our racialized communities here have really suffered disproportionately, and there's a huge socioeconomic piece, of course. So that's number one. Our experience is not the same, therefore the way we describe and label it will not be the same. But I think even the second thing, there have been many surprises for all of us, and this is where, for me, again, the work, I often joke that the mindfulness training was probably the best pre-pandemic preparation I could have ever done in my life, because, really a lot of it has just been accepting that, for example, in the first couple of months of the pandemic, my brother died, and I already had a very complex relationship with my brother, in a sense, in terms of he had suffered for most of his life from severe schizophrenia. And actually, it's a piece that I think is in the chat that I wrote in the LA Times early on in the pandemic about, this kind of experience. Some people might call what I experienced disenfranchised grief, but it was even more complicated than that, actually. And so, if you say to someone, I lost a family member in the pandemic, we can't lean into each other and say, oh, I know what that's like. I don't know what your experience is like, and you don't know what mine is like. And again, that's why we come into community, right? To talk, to find out where there's intersection, to find out where we don't share the same experience of loss. So it really is, we think this is a universal trauma that we've experienced, but on one hand, that's true, but the degree, texture, the impact, and the lifelong impact for those, something like 6 million children, I think, in the US have lost, as of a couple of months ago, a primary caregiver due to deaths from COVID. So either a parent or an individual that they identified as a primary caregiver. So for those kids, their experience is not the same as the experience of my children, whose lives have been really disruptive, but who have not experienced any gross instability, financial or personal. So I think that's, again, where this idea of the more conversation, the better. The more we understand each other's losses, the better. And the more we leave open the opportunities to name, label, frame, explore, the better the chance we can come out of this, understanding the degree of pain, but also, where we've shown resilience and where there are places for hope too.
Christina, before you go on to the next question, Jill doesn't know this, but she opened a door to a question that I was going to ask later, but it seems like the perfect opportunity now. And if you were watching me on camera, you saw that I dipped out of frame because the piece of paper that I was so excited to reference fell on the floor, but I have picked it up. And here is the funny thing that Jill referenced that I want to take advantage of, if you guys don't mind. You mentioned your LA Times piece. And of course, in doing my homework for preparing for today's hour together, I did read that LA Times piece. And you said something that I wanted to just pause for a second, because it's about laughing and it's about humor. And it sounds like it's a bizarre thing to bring into this conversation at this moment. But let me quote. I have a quote from Jill right here. It says, from your LA Times piece, "From the first day I wore my white coat, I used humor as a grenade to lob at situations that were too awful for words." Tell me about that. Where does humor fit in to your work as a doctor?
Yeah, it is so critical. I don't think I could be a doctor without it. And actually, that quote, Allison, comes from, I think, a different piece that I wrote for the LA Times, because I have the privilege of
Oh,
writing
I'm
quite a bit
sorry.
about it.
You're
That's
so,
okay.
you're
I'm
so
lucky
prolific.
to get to. Well, that comes from a piece that I wrote about the deep informative impact that Hawkeye from MASH and Alan Alda's body of work have had on my life and my identity as a physician. And of course, that was growing up in a home with two profoundly disabled siblings, both of whom have since died. But, really for me, and I think this is relatable to so many of you and really everyone who's had a major loss in life, the places that we find humor are so often unexpected, and sometimes the people around us make them taboo. We're not able to express the full range of our experiences, in particular when they include laughing at things or memories or situations that other people might think, well, how can you laugh at that? So, this way of being that I learned through my deep attachment in early years growing up in a very challenging home, to Hawkeye, Hawkeye's use of humor as resistance. I think it's one of the best tools that I have in my toolbox when I, in particular, not just facing my own life, but looking after patients who are facing life-altering and frequently terminal diagnoses. I think the careful, thoughtful, well-placed use of humor. I also say in that article that humor is shorthand for hope. I think when you can make a joke, an appropriate joke, a joke that you understand that the other person is going to find comforting, that shows that you know them, that is, again, this is a skill that comes with time. It can also be very badly used. I mean, it can be hurtful if people are using humor inappropriately. So it's a skill, really. But for many of us, it's a learned skill that is part of what we emerge from loss with, a different outlook and the understanding that in those, very darkest moments of our lives, even there, something can glitter, that we can find these surprises. And it's that, for me, I think is one of the things that has carried me through not only difficult experiences in my life, but also some of my most difficult moments as a clinician.
Hope, I relate to this. You and I have had some amazingly fun times and filled with humor.
We have, yes, we brought 16 women to Peru on a trek, and we laughed our way through Cusco and all the way to Machu Picchu. But, people say to me, wow, you're going to lead a grief retreat for 3.5 days. That must be really sad. And I say, at times it is. We use plenty of tissues, but there's so much laughter as well. Because laughter often comes from relief, this sense that I'm with my people. I'm with people who understand what I've been through. I agree with Dr. Horton that labels are important because they can validate and normalize an experience, but we can also get that through community. We don't have to do it at home, just adopting a label. And I also want to point out that the question about COVID, if we have all grieved, some of us, or had losses, some of us more than others, clearly. But asking, do we all have that disorder, means the cat's out of the bag. The idea of a disorder has already entered the lexicon. Do you see? We're already languaging, using that term disorder and applying it to grief. And that was my concern. Allison, I see a really good question in the chat box. Is it okay if I pull it?
Yes.
I'd like to speak to this, and maybe you and Jillian would like to as well. It's from Michelle, and she says, I feel like the grief I'm feeling around the COVID crisis and all the related loss has brought back up past losses for me, and I am grieving them again. Is this just me, or are others feeling this way? That's what I would refer to as reactivated grief. It is really common for a loss to evoke in us certain physical feelings or emotional sensations or thoughts or memories that are very similar to those that we have experienced in the past. And in that event, we may find that we are going to reassess a past loss and maybe grieve it in a different way or with a new set of eyes. But so I want to say, yes, it is very common for that to happen. And I work with clients on this all the time. But what I want to impress is that doesn't mean that your grief was incomplete in the past. It doesn't mean that you did it wrong somehow. It doesn't mean that you have a disorder. What it means is that you are cycling back. I think of grief occurring in cycles rather than in stages. You are cycling back, perhaps to grieve a piece of the loss that you weren't able to grieve at that time in the past because you didn't have the maturity or the experience or the wisdom that you have now. There's no disorder in that. There's no shame in that. This is how grief works. We are constantly looking back at the facts of a loss and experiencing them anew and differently at different points in our lives. We're looking back at the same set of facts with different perspectives, and we might have a grief response around that. I mean, for example, I could not pre-grieve what it would feel like to reach the age and pass the age my mom was when she died. There was no possible way I could have done that at 17. I couldn't even do it at 35. I could only do that at 42 and 43 when I reached and passed that age. And that was decades after the loss. Did that mean I have a disorder? No, I think that's how this long-term process works. In fact, if anything, I think that's normative. And community and being around other people who've experienced the same can give us that sense of comfort. Jillian, when you were talking, I was thinking what a difference it would make if prolonged grief disorder were called prolonged grief experience. Instead, just that little tweak could make a big difference in the culture.
Yeah, what a great point.
It could.
Mm-hmm.
Christina, I would love, with the remaining time that we have left, are there lightning round questions that would be short and quick for Hope and Jill? And if not, I have my own final wrap-up questions, but fire away.
Okay, this isn't lightning, but it is important. So can you talk about regrets, guilt, and helplessness after a loss?
Yeah, that's not lightning round.
Yeah, it's not a really quick topic, you know.
Dr. Horton, do you want to take one of those?
Absolutely. Well, I'll tell you again, I've shared that my work in mindfulness, but also again, just really to highlight that that's not mindfulness sitting in my own house by myself, reading a book on a cushion. That's coming into community. And it's the community piece that's so healing, as Hope and Allison have already alluded to. But, for me, that has been the skill set that has allowed me to go near so many of the things in my life that have continued to give me, have continued to be sources of aching and pain and discomfort. And as Hope said, a lot of what I have learned to do with that skill set, I think of it sometimes as building my tolerance, allowing me to sit for longer with those experiences, to get a little bit closer to them, to learn skills to work with them a little bit differently. And for me, I've had lots of regrets in my life. I mean, my siblings, in terms of my own experiences with grief, both of my siblings had particularly awful lives full of chronic suffering. My parents had incredibly difficult lives caring for them, in my sister's case, until literally the end of her life. So, for me, and this is a big part of what I write about in my book, that, moving through those experiences, and really what Hope said just resonates with me deeply, learning skills to work differently with them, as opposed to just expecting them to change. I mean, they do change, but seeing it as an active process, learning how to lean towards as opposed to step away, has probably been the most transformative
Very much.
skill in my life. Yeah.
Jill, I'm going to have that be your last wrap up thoughts today. That doesn't mean we have to end speaking with you. So just again, your book is called We Are All Perfectly Fine, and your Twitter handle is Jillian Horton MD. So please reach out to Dr. Horton, get her book, and Hope, I want, in the 3 minutes we have left, there are lots of questions about your retreats that are coming up this fall. What is the website where folks can find out more?
Motherlessdaughters.com. We will be registering for the October retreat in Connecticut later this month. And in the meantime, they can read about all our other services, including weekly calls for motherless daughters on Tuesdays and Thursdays. They are low cost forms of support, women from all over the world of all different ages. But could I say just one thing about guilt and regret? Because I would like to leave this, if these could be my parting words. I work with a lot of clients who are experiencing guilt or regret after someone dies for things they wish they had done or things they did that they wish they didn't do. And what we do is we can do some revisiting and reframing of those experiences in the past, but then we also look at the present and the future. How can I unpack what it was that I'm feeling guilt or regret around? And how can I not be that person or not do that in the future? Let's create an action plan where I can balance that scale a bit by doing it differently next time, by finding an opportunity where I can do it differently next time, where I can go out into the world and be that person that I wish I had been around the experience that I'm feeling guilt or regret with. And one way to do that is what I call next generation repair, which is to give a child what we didn't get or wish that we had given ourselves permission to have, or wish that we had done for somebody else, so that that legacy of good works or good deeds in the world can live on.
Hope, I love that. I love that. And your wisdom lives on at Hope_Edelman on Twitter. Your wisdom lives on Instagram and on Facebook, Hope Edelman author. And I am so thankful to Reimagine. I am grateful to Domani for Grief. Without their sponsorship, this series, the last Thursday of every month, simply would not happen. So as promised, on the nose, top of the hour, thank you guys so much for being here. This is the highlight of my month. I am so glad to be with you now, and I can't wait till next month with Pastor Corey Kennard. And I'm grateful. You could follow me too. I'm not going away either. Facebook, Instagram, Twitter. Let's stay connected. Thanks, everybody.
Thank you so much.
Thank you, Allison, and Reimagine.